Welcome back, everybody. I'm Sarah Imond, ICER's President and CEO, and it's my pleasure to join you now for our Policy Roundtable. I'll ask all of our Policy Roundtable participants to come on camera as we start this next section. As they do so, and before I ask them to introduce themselves, I do want to frame a couple of things here. We are uh, so lucky to be in this moment where a once fatal condition, we now have the privilege of sort of talking about the evidence on a new therapy that might help them regain some muscle mass. And I just wanted to make sure we put into context what amazing innovation we have seen, and how meaningful that is to patients, for this community, for those of us with deep empathy for this community over the last 10 years. And so let's carry that awe and wonder as we get probably a little wonky today, a little bit in the weeds at times. Apologies in advance for doing that. But why don't we go around and have each of the members of this policy roundtable introduce themselves? You see on your screen any disclosures they have made. I'll ask them to just give us any updates if applicable to those disclosures. Dr. Thomas Crawford, if I could ask you to go first, please, if you're back. All right, we'll go back. We'll circle back to Tom. Oh, here he comes. I think his camera's coming on. Tom, if you want to just say hello, introduce yourself, and see if there's any updates to your conflicts.
No updates to my conflict. I'm Tom Crawford. I'm a neurologist who major interest in spinal muscular atrophy for a long time.
Thank you so much for being here. Giles.
Hi all, I'm Giles, the Chief Exec for SMA UK and twins, father of twins of SMA kids, and there's no updates to my conflicts.
Dr. Hugh McMillan.
Yeah, thank you. Hugh McMillan, pediatric neurologist, neuromuscular at CHEO in Ottawa, Canada. And there's no updates to my conflicts of interest.
Lindsay Samara.
Hi, Lindsay Samara. I am manager of outcomes-based contracting and pharmacy programs at United Healthcare, and no updates to my conflicts of interest.
Thank you, Lindsay. Portia.
Hello, Portia Thorman, Head of Advocacy and Community at SMA UK, and mum to a little boy with SMA type 1, and no updates to my conflicts.
Thank you. And Emily.
Hi, Emily Shao. I oversee our drug medical policies at Premier Blue Cross, and no updates to my conflicts of interest.
Fantastic. We're going to hit on a couple of different themes today. We're going to dig into the evidence that we've discussed, what it means for price and access. We will keep sustainable access for patients top of mind as we have this conversation. And I do also want to say that we're disappointed that Scholar Rock chose not to participate in this roundtable. We do believe at ICER that the only way we're going to move forward with what I think most of us can agree is a pretty dysfunctional system right now, that we all have responsibility for working towards it being improved, and that means everyone has to show up. And so we hope that in the future, manufacturers will continue to engage and come to defend the value of their medicines. And a couple of the things top of mind for me that we'll dive into. We talked at the top here about how lucky we are that we're in this moment where there have been effective disease-modifying therapies and how transformational that is for this community. And how do we think about pricing for something that's not disease-modifying, right? We've had a lot of conversations and we've had a previous meeting on spinal muscular atrophy, but here we are with this new therapy, apitegromab, that offers a benefit that patients and their families care about, but it's not necessarily disease modifying. So how does that play into everything from the pricing, the coverage, the access? We also, and this came up in our previous conversation, and I just wanted to make sure that this was clear. Given the votes we just saw, where most of our CEPACs agreed that the evidence wasn't really there to show a net health benefit for this new therapy, to understand which of the disease-modifying therapies work best or which one should be used for which patients, we do want to acknowledge that it is difficult to generate evidence in ultra-rare treatments. And so we want to make sure that that is like out in the open. You can't have a 10,000 person randomized controlled trial. It's not a cardiovascular outcome study for a GLP-1. So we want to make sure that we acknowledge there are real challenges with generating evidence. And I also want to say that there is nothing about our conversation today that is taking away from our firm belief that the disease modifying therapies are transformational. So this is not to say that we think there should be any restrictions on access, that there's anything to say clinically other than, yes, let's continue to make sure those are available. But we will talk about where we have some desires for future research needs, where we would like to have some more data and where we think about the benefit or the balance between pricing that rewards innovation and has a good return on investment for investors with affordability that I think many of us have experienced. All right, to get started, we're actually going to talk about health equity. Now, that's something that we always want to just start every meeting with and make sure we're talking about. Today, we made a vote on special racial or ethnic populations that we should be worried about. Not a lot of evidence that that's a problem. I did want to just go around, especially for our clinical experts and our patient representatives, our caregivers. Is there anything from an equity perspective that comes top of mind for you when thinking about the introduction of a new therapy like apitegromab or even access to the existing therapies? Portia, can I start with you if there's anything that you think about from a health equity perspective in this issue?
Yeah, sure. I think at SMA UK, certainly, I don't know about the rest of the globe, but we do struggle to access that part of the community. So ethnic minorities in the UK, they tend to keep themselves to themselves. They don't reach out to us. They sometimes see the word charity as being a negative. You know, they're very much of, we have each other, we have our support systems, we don't need charity. What that means is that we don't have these people on our database. They're not engaging with us. They're not getting our social media, our emails. So quite often they don't even know about the advances in therapies. Because for a lot of people, we're the first point of call. We let them know about what's happening in the SMA landscape. And if they don't know, then they can't access it. I think if patients are on risdiplam, as we've already discussed, they're not going to their specialist clinicians so much. They may be quite happily taking their risdiplam. It gets delivered to their door. There may be no reason for them to go to a healthcare professional and to find out about these new therapies. So I do think that the communication is an issue before even the treatment choice decision. I think, just finding out about these new things has been a problem. And for us, we work with organizations who reach out to ethnic minorities and go to where they are to inform them about these things.
I appreciate that, Portia. Tom, could I call on you for just a balance of like on the US perspective side? Is that something that you've seen in terms of communication?
So the most amazing day of my career was the day that the FDA approved Spinraza, December 23rd, 2016. The worst day was 4 days later when they announced the price. And it's like, oh my God. I did not imagine that, in fact, price has not been a great barrier to getting DMTs to patients with SMA in the United States because of all these combinations of backdoors and other sorts of things and companies not wanting to look bad. So that was an insight.
Okay.
There are, however, difficulties when people are in mobility. So our weaker folks have a lot of difficulty getting to the clinic, and as a consequence, they don't get the supportive care. And in some ways, the ability to get risdiplam at home undermines that because they say they're getting the therapy, and then they don't come in and have the things that they actually really need, which is attention to lungs and breathing and all that kind of stuff. So there's a big inequity built into severity. I don't know of an ethnicity or cultural barrier associated.
Tom, I really appreciate that. As we have learned from our engagement with the disability community over the years, just the loss of mobility and then coming up against the barriers of our current built environment and even biases that can be built into either the healthcare system and other things. I thank you for making that point. We'll make sure that we highlight that. Giles, just to you, anything else that you wanted to add on the health equity piece, please?
I think it's an interesting point. Obviously, the main focus is always around children, but obviously the adult population as well, accessing treatment is particularly difficult. Obviously, access to get to visits at hospital, etc., can be really, really challenging trying to coordinate that. I think from just a little bit on the price perspective, obviously it's not so much as an end user as a patient, but there are difficulties in terms of making sure that the regulatory bodies deem that their quality scores are appropriate to the price of the medicine. Now, obviously, most of that is we don't ever see anything in that because it's all commercial agreements.
Right.
But when you look at the list price, like Tom said, 4 days after the 23rd, it is still super high and really, really kind of worrying for a lot of clinicians and decision makers to say, is this effective? And the health economics are effective as well.
Thank you, Giles. Hugh, anything you'd like to add?
Yeah, the only thing I'll add, and Tom will have to comment if this is an issue in the US, but we do find that equity potentially can be an issue if an individual has a complex spine and if they're living in a city or a community where there's less comfort administering intrathecal dosing when there's scoliotic rods in place or with a complex spine. So that is one thing we do observe. That's the one thing that comes to top of mind. But again, I don't know if that's a significant issue in the US.
It most certainly is. And, the companies are trying to come up with either longer acting drugs or ports or other sorts of things to try to solve that problem. It's the same issue if not everybody can get to it. Whether
you have the attention of two payers who think about things like coverage policy. Is there anything on the insurance side that has made that challenging, or is that more the anatomy of the scoliosis and getting the right providers? Is there anything that we want our insurance colleagues to know to help address that, or any of the other
yes,
equity issues? Please go ahead.
there's this. So if I had a therapy that stopped ALS from deteriorating, it would be the most remarkable thing in the world. We know that we have long experience with SMA that folks in the absence of therapy decline very slowly, but they do decline. And so the idea that we're going to afford stability especially in adults is somehow not good enough because they want to have the benefits that the babies and the children had. And so this is a big problem because the requirement is that we show benefit improvement, and that is a very high bar that is not infrequently not met. And so we struggle. And in my case, I usually win, but I know that a lot of people don't.
I really appreciate that point. We'll bring that through. Fair warning to Lindsay and Emily that when we start talking about coverage policies for apitegromab, how we can balance that, because we've heard that in previous reviews and things that we've done. We go back to our first Alzheimer's review, which was notable for a lot of reasons when we looked at ADUHELM that we don't need to get into today. But one of the things that we heard loud and clear from the patient community and the carer community was stopping disease progression or even slowing it is of value. And so how do we translate that into a responsive coverage policy? So we're definitely going to get to that. Hugh, I see your hand. Sorry, Tom, please, if you wanted to.
I point out that if the issue is slowing the rate of degeneration, there is no individual patient ability to show that. If you lose something, then obviously it's not working, even though the background is essentially it is not possible to demonstrate that.
Understood. Thank you. I got you. Hugh, go ahead.
One other piece that's an accessibility issue that came to mind is the need to have qualified and competent evaluators that are conducting the motor outcome scales. And the reason why I say that, Sarah, is because if an untrained individual gets involved and someone's score jumps up because they're overly optimistic, don't carry it out properly, and then the subsequent score drops, that can be a cause for terminating therapy. So it is really important that that the individual be trained, that they carry it out in a systematic way, and that's an issue for some centers and some cities if they lack that.
I think I really appreciate that point. We're gonna talk about that. Portia, go ahead.
Yeah, just following on from that, I think it's really important that patient-reported data is collected as well, because if you take a child into these measures and, they've traveled a long way, they're tired, they're not ever going to perform as well in a clinic environment as they do at home. And we have parents that say it's so frustrating because I know they can do it and they've done it at home, but they won't accept this video evidence. So I think PROMS is super important.
I agree. I agree. But I will acknowledge, and maybe Lindsay will build on this. Sometimes that's really hard to write in a coverage policy. And we need flexibility to make sure we understand that these things might not be linear, that there might be a bad day. We in our just recently completed review on multiple sclerosis, where there are similar types of scales of motor function that help to, see if someone is improving or not declining. We had a clinical expert who reminded us that they had a patient who came in who was just recovering from the flu, and they like bombed their assessment, and then it was a fight with the insurance company because they're like, well, the drug's not working, and then it's like, well, they just had the flu. So I appreciate that point, but Lindsay, I see your hand. Please jump in here.
Yeah, thanks. I do want to build off of the need for the patient-reported outcomes, but also the patients that might not be able to get to the clinic very often, and figuring out how do we still get information about our patients, like you just mentioned, when they receive therapies like this. I mean, this is a rare disease, and especially, we care for so many members, but there aren't that many members in this patient population. And so something that I think could help with that long-term assessment and just knowledge sharing is really understanding how are our patients doing. And if it's patient-reported outcomes, I think that's fantastic. If it is getting some sort of physician to go out there, do the assessment, or vice versa, getting them into the clinic more often, I just think getting those data points could go a long way.
If you would allow me to build on that a tiny bit, we should be thinking about taking advantage of telehealth and other technologies potentially to be able to make the longitudinal sort of assessment of how patients are doing on therapies a lot easier for everyone. And so it's not necessarily going into a clinic and things like that. Does that seem fair, Lindsay?
Yeah, absolutely.
Okay, great. Tom, please go ahead.
There's one other wrinkle that I just remembered. It was the nature of the initial nusinersen study that it was stopped early for futility because it was unethical to continue the trial any further. The magnitude of the benefit was so profound.
Okay. Right.
However, there were some patients who were not better at the end of it than they were at the beginning. And that opened the door to the waterfall plot rather than the average outcomes with a thing. That meant that we have since having to prove that this patient is a responder as opposed to a non-responder. That opened the door to that criteria. And to me, it was the appropriate thing to do in the setting of that trial, but it opened the door to having to prove that somebody responds, which is not it's not possible. So we're burdened with that history.
Is there a particular change in a policy, in a clinical approach that you would recommend to address that issue? Or is that just context for the understanding this evidence base?
I think it's context for the evidence. I mean, there's no therapy that is going to be always better at the end of it. That doesn't mean that the drug isn't working.
Right. Okay, helpful. Thank you. Portia, please go ahead.
We've had a really big problem with PROMS in the UK because Spinal and Risdiplam aren't yet fully licensed. They're going through a managed access agreement.
Got it.
So we are continuing to collect data every 6 months. And part of that is the PROMS collection. And as families, we're expected to do it online 6 months before or 6 months after our clinic visit. And now we are at a point where all that data has been submitted and an external assessment group has looked at all the data, and they've found that families just haven't been doing it. We know the importance of it, but we've got busy lives, and to be honest, we just forget to do it. And so people are, you know, people are saying, oh, it's the patient's fault that we haven't got good enough data to get these drugs through. But actually what I think needs to happen is if we're coming in every 6 months, we are waiting a long time in that waiting room. Give us an iPad whilst we're there. Make us do it at that point of the clinic. Do it while we're waiting. And that would make it a lot simpler, because all these sort of remote health apps and stuff are all very well, but at the end of the day, we just forget. So you need to be presented with a tablet when we're in clinic, and then we can do it there. I think that's
I appreciate that. I think we all are like, well, we'll just have an app for that. Seems to be the answer to everything. And like, how many apps do we all have on our phone that we never open? And so I appreciate that perspective. Thank you, Portia. Before we leave health equity, and we have a few threads I'm going to pull on as we go into other parts of our conversation, one thing I did want to acknowledge, in the US system, we now have newborn screening as part of every panel in every state. But given our colleagues from the UK have given us so much of their time today, Giles and Portia, is anything that you want to say from the UK perspective, or even internationally, about the importance of newborn screening and where we want it to go?
Yeah, absolutely. So it's obviously the long story short is we do not have it in the UK at all. So if we look at, you know, compared to Europe have 66% of Europe that are completely doing newborn screening. The US, you guys have got 100, and I think obviously at the most recent Cure SMA conference just last month, the aim in the next couple of years is 18% of the world will have coverage by the end of 2027, I think it was. So where we are is we are a long way behind, and it makes a huge difference. We're waiting for symptoms to be demonstrated in a clinical setting, and as we well know, that's too late. You know, we've lost the opportunity to really change the disease progression. It's something as a charity, it's our kind of number one strategic priority that we are constantly working with. The biggest difficulty is the red tape and bureaucracy within a UK system, which is particularly challenging. And we're not really seeing the common sense opposed to actually the red tape, as I mentioned. So it's very frustrating. But I think we've got a lot of examples now across the UK where children have siblings and have been treated pre-symptomatically. So we know that's there. We know that those outcomes. It's just about really trying to work hard and being smart to try and make parliamentarians, etc., actually sign things off significantly quicker.
Thank you, Giles. Portia, please.
I think it makes an additional hunger for add-on drugs like apitegromab in the UK and for dual therapies. Families in the UK are desperate for dual therapies. I'm really excited about apitegromab because we have a bigger unmet need than other places in the world.
The point is very well taken. Hugh, Canadian perspective, please.
Yeah, and I would just add to that about the newborn screening is there was a very good systematic review that was published by Aragon Gowinski in 2023. They looked at 18 different publications, including the pivotal trials for each of the approved therapies. They found for the 2-copy patients, if those children were treated pre-symptomatically, the likelihood that the children would walk was in excess of 75%. But if the children had signs of clinical symptoms at the time of their initial assessment, and again, even if that was on a newborn screening, less than 20% of those children would be able to walk. So it speaks to how critical it is for us to be identifying these kids with newborn screening, and for us to be either bridging or moving ahead as quickly as possible with therapy to maximize the survival of motor neurons.
I appreciate any time we get to step a little outside our US box. And so we'll make sure that this works its way into our policy recommendations about building on the example of the US, getting to 100% state, in the newborn screening, what that means ex-US. Lindsay, please go ahead.
Yeah, so I am from the US, so not a non-US opinion, but what I do want to say about the newborn screening is it is a really high value add. I mean, even outside of just the drugs and what they cost and everything, the newborn screening coupled with what therapies we have and treating early, like everyone else has just stated, is really high value. And so I feel like it can't really be understated of how important that time frame is. And at least from a coverage perspective and how I would approach it from that policy lens is if we have that newborn screening and it's confirmatory, it's given to us, or we have a case that's coming into be reviewed by us, we are not going to be the delay in care by getting that policy reviewed for that patient. So I do just want to say that, you know, I am the biggest supporter of newborn screening, and it really is of high value here in this space.
That's great. That's great. Thank you, Lindsay. Tom, please go ahead.
Just the small observation, when newborn screening first came in, it was a little bit controversial at the recommended universe screening program, the RUSP thing, and apparently a fair number of people voted against it because they didn't want to obligate the very, very expensive medications disproportionate to a small number of patients. And so this was a health equity thing in small states. But the interesting thing has changed is that it actually doesn't save any money at all, because if you diagnose a kid at 4 months or 6 months of age from weakness versus at newborn, they're both going to get the therapy. They're both going to get the encumbrance on the budgets. One of them works and one of them only works a little bit.
Well, then you go back to the patient who would have been much better off getting it right after being screened, right? And so it makes it, I don't want to say a no-brainer, but we're getting close to no-brainer territory when we have effective therapies and we have screening.
And I would just add, just for really quickly, I agree wholeheartedly with what you both said. There's very good data from health economic modeling that shows that if we wait until there's symptoms without newborn screening and we treat, it costs the system so much more than if we screen and then treat pre-symptomatically.
We did a review earlier this year on a new medication for pain, suzetrigine, and our modeling showed that it's probably cost saving to the healthcare system because it's likely non-addictive. It's avoiding a lot of cases of opioid use disorder. And I remember being at that meeting being like, we don't get a lot of times where we get to say this is cost saving. So with newborn screening, we don't get a lot of times when we say this is clearly cost effective. And so I appreciate everyone's comments on that. We'll make sure that gets worked into our recommendations today. Let's shift to talking a little bit about and reflect on the votes that we heard today from the Midwest CEPAC. And so we had a couple of different clinical questions that we were asking, both on apitegromab, but also the disease-modifying therapies. And so if we look at the apitegromab example, our Midwest CEPAC closes to a split vote. It was 8 no, 5 yes, that the evidence was adequate to say there's a net health benefit with apitegromab. So this was our closest vote today, where there's definitely some members of our Midwest CEPAC seeing that net health benefit. ICER gave it a promising but inconclusive, so a little bit worried about the harms and the magnitude of the benefit. I want to start with the clinical experts. Tom, did that vote outcome surprise you? Like, tell me a little bit about how you were thinking about the evidence. We heard from your conversation today, how you were thinking about it, but share it with this audience if you would.
It did disappoint me because all the issue about MCIDs and stuff like that, all the patients wanted to stay on it. So that was, and that's despite the fact that they have to come in and have be stuck in with an intravenous infusion once a month. Sometimes those IVs are hard to get. So there's significant burden associated with it, and yet everybody wanted it. And in my own experience with patients that I know personally, they all told me something that was believable that they could do, but it was below the threshold of a Hammersmith point. I can lean over this. I can reach that. I can do things along the level of this is meaningful, even if it's not measurable on your scales. So actually, I was kind of disappointed by that, and I hope I don't know how we're going to repair that defect.
No. Well, this is our opportunity to reflect on that. We're going to pull in also future research needs, because I think there's also the opportunity for, well, then what other research should we be doing to sort of answer this question and help? So we'll get to that.
Well, certainly the fact that this we have this result should create a movement to improve on our research stuff.
Yeah.
This was done by a small company with a very limited budget against a background of about $1.5 billion spent on myostatin inhibiting drugs that did not work. And so they didn't have a lot of resources to design a study that was going to be powerful. And the one they got was pretty sketchy, but it crossed the line.
Got it. No, that's helpful. Hugh, anything you wanted to add on that?
Yeah, no, I would echo what Tom said. From what I have seen presented at conferences, from my awareness of what's been shared, from the results of the TOPAZ study and the preliminary SAPPHIRE, it does appear to be demonstrating some clinical efficacy. It's not as profound as the other disease-modifying therapies that are starting earlier, but it does appear to be offering benefit and attenuating the phenotype. So that's my impression as someone who has not been involved in those clinical trials, but's been keeping abreast with the literature.
Emily and Lindsay, let me put you on the spot. So what does that vote mean? How does that land for you guys as you're starting to think about developing coverage policy, which we'll dive a little more deeper into the specifics of that. Anything that surprised you about that discussion or that vote?
I mean, so not so much surprise, but for me, the takeaway was that we have to have a very clear process on the back end to do these reviews and these requests, because there's the policy, which is the standard, but I just want to emphasize how important it is to have a really solid process in your prior authorization review for being able to escalate contextual factors that are found in the medical records and how important that is. And so we're fortunate that we do our prior authorizations in-house and do have that process and that ability to be flexible. But I also want to call out that, I think we're also really fortunate in this disease state where, at least in my experience, the medical records, the specialists, I would say it's a fairly collaborative area where, if we reach out to the specialists, we have additional questions, those calls are answered, and the medical records we received are detailed. They have some of those contextual considerations, and so that makes the whole process much easier. So I would just advocate for, in that process of review, providing as much information as possible. If it is a bad day for that patient, when you did that evaluation, call that out. And I think that would make a huge difference.
Thanks, Emily. Lindsay, anything to add on that?
Yeah, I would say, when we're developing our coverage policies, it's a balance with all of the information that we have at our fingertips, whether it's a marginal net benefit, it's a small net benefit, or if it's inconclusive. We take all of that information and, as Emily said, try to put it in some sort of logic that can systematically be applied patient after patient. And it's definitely easier said than done. But at the end of the day, we're here to make sure that the right patient gets the right drug. And we do that through our coverage policies and incorporate the information that we have available.
One thing that I will encourage us all to have as a theme throughout this conversation, is we heard it a lot in the testimony today, in the deliberation, whether or not this word was used. I wrote it down several times. I was like, patient heterogeneity, whether it's the measurement, someone was just sick, or they have a different presentation. That demands of us a flexible enough insurance policy system to be able to account for that, while still balancing the tension of writing a coverage policy for a population, right? And so, like, we're just going to kind of name that tension exists, and I'll be thinking creatively about how the coverage policies can reflect that in a way that makes it as burdenless as possible for access, knowing that we're going to have heterogeneity. Great. Before we move on from that vote on apitegromab, I just want to make sure, Giles, Portia, anything that you wanted to add about that vote, please, Portia.
There's a big problem here with measures. This decision, based on the data, I would have voted the same, to be honest, on the data we have, because the measures are not sensitive enough. But from sitter to non-sitter, there's so much between that. With my son, the biggest thing that impacted him, the first thing he did when he was 1 was being able to hold his head up.
Yeah.
That isn't there anywhere on a measure. And then we went from holding his head up to sitting in a spinal brace. Now, sitting in a spinal brace is very different to sitting without a spinal brace. So we could sit in a spinal brace, and then at some point, we were able to take that spinal brace off, and he was able to sit propping himself up. And then he was able to sit without being propped up. There are so many small steps between not sitting and sitting. It's just ridiculous, which, again, and I know I bang on about this, is the importance of recreate. It really frustrates me how insensitive these measures are for SMA, and how the small increments can make a huge difference for someone's quality of life. Can you imagine not being able to hold your head up and look around? The difference is massive. So you can't judge whether we should have treatments or not on the clinical data that we have now. It needs to be judged on
Real life.
I mean, someone needs to invent a better scale. Without that, we need to be looking at patient-reported data and how these small increments of improvements have such a massive effect on quality of life.
I agree
just-
completely. And please, Giles, please go right ahead.
Yeah, no, I was just going to come in and say, I think there's a comment you mentioned earlier around what is marginal benefit, and that's exactly what Portia's described. Those marginal benefits are hugely important to the community. It's very, very different to quantify that within a research, within PROMs, within a Hammersmith, etc. But those marginal gains are huge. And if you look at the kind of bigger picture, if the majority of people now who are on treatment are actually either plateaued or maintaining their current state of movement, to have those little marginal gains is hugely important. So it offers a little bit more hope, a little bit more opportunity, a little bit more potential to do something extra. Now that extra could be massive. And we've discussed this before in other forums, but like Portia mentioned earlier, that could be the difference between a carer lifting your hand onto a power chair or you doing that yourself and having essentially full independence to go where you like. Now that marginal difference, marginal gain is massive. It's absolutely massive.
Wiping your own bottom, there's no scale that measures that. But
I'm putting that in the policy recs, Portia. No, you're not wrong. And I was really struck by I broke my leg skiing 4 years ago, and I had some limitation to my mobility for a period of time. And I remember being able to sleep on my side again was like an amazing milestone because I couldn't.
Being able to turn. We have night nurses here. We have nurses 12 hours a night. That costs the NHS an enormous amount of money because he can't turn himself.
Right.
Yeah.
Right. And those are real benefits. But Lindsay and Emily, to you, those are hard things to write into a coverage policy, right? Or no? Tell me I'm wrong. Go ahead, Lindsay.
No, those are not going into a coverage policy. But I think Portia keeps hitting home on the importance of patient-reported outcomes, which I don't necessarily have easy access to. It's something as an insurer, I think I would like to have access to. And especially if we go towards the direction of, outcomes-based contracting, which I support. These are all data points that I think can help tell the story of the success of these therapies and treatments and all of the efforts that are going into helping these patients reach these monumental milestones that on paper, when we're looking at different Hammersmith scores or what other type of scores you have, it's important and impactful. So I do want to say, like, data is an issue, and having access to important data is an issue. So any barriers that we can overcome in that space, I think, can help make those coverage determinations.
I appreciate that. Emily, anything to add there?
No, Sarah. I think the only thing that I would add is, just the importance of educating your team that does these coverage policy reviews and making sure that they have a really comprehensive understanding of the condition. I think that makes a big difference right at the get-go.
I love that. We'll make sure that we weave that into some of our recommendations. Let's move on to some of the other votes that we had today and some reflections. I'm going to take the next two as a group. And so we did want to, and we had this as a research question that we were very interested in understanding of whether or not we had evidence that it was beneficial to add risdiplam or nusinersen after getting Zolgensma. I will not torture the audience by attempting to use the generic name for Zolgensma. And there the votes were 12-1 in both cases, that no, we didn't have enough evidence. And that bummed me out, not the vote, the fact that I would have voted the same way, which is we don't have data to know, and yet families are wondering what they should do after this. And if I could start with the clinical experts on this, do you share that frustration in your practice that you don't know the sequencing, which one is better if that's a case, or whether or not you should be using it? Or is this question kind of answered for you? Tom, can I start with you?
I seem to be the first always.
I'll switch it up next time.
No, that's okay. I personally think there's no evidence to suggest a difference on the efficacy side. And so when I counsel families, I say, look, what is the perception, and I emphasize the perception of burden rather than the actual burden. perception of burden in spinal on this nurses, obviously the spinal taps, and that's big. But I have some families that have their kids have spinal taps, and it's not a big deal. They just do it. They like that kind of reliability. The perception of burden on the gene therapy is you don't know its durability. You don't know about the side effects. There's a small but meaningful serious outcomes. And if how would you know if durability was lapsing? Because we don't have assays that do that. The perception of burden on the orals is that it might have other off-target effects that we don't yet know about, and that was a big deal initially. It's less of a deal now for the older ones. It probably, in my mind, is still an issue for the newborns because gene expression is highly variable in fetal life. So all those things are meaningful. But unknowable. So to me, the initial step is we discuss it, and which perception of burden is the most meaningful to you. Now, as far as the second drug, I'm in a real quandary here. In fact, it happened today. Somebody wants that second drug because they don't like the benefit that they've been having, and I'm not in a position to say you can't have it, because actually I could probably manipulate a situation where we would prescribe it and maybe get it. I don't know. I'm a scientist too. I want to do stuff that matters, and so on the science side, I'm troubled by the fact I don't have it. On the human side, why am I going to deny them what it is they want, the hope that they want? And so it's which Crawford are you talking to?
Both, right?
Yeah.
I mean, it's hard to separate that out, and we experience that in our work as well. Just to make sure I understood that case, they've had Zolgensma, then they're on nusinersen, and then they want to switch to risdiplam.
This one was a kid who's on Spinal who wants to add risdiplam, but it's both situations.
It goes that way. Yeah. Okay. Thank you, Hugh. How about you in terms of thinking about which one, the sequence?
Yeah, I think that the concept of combination therapy or add-on therapy is a huge challenge for us. I think in general in society, there can be a sentiment that more is better. So if you give more of something, then there'll be a better response, which is not always true, and sometimes it actually potentially can be the inverse of that. I think there can be fear, as Tom pointed out, of how will we know if therapy A is not working or therapy B wears off. There can be a lot of fear about that. How long will it take us to recognize that? How many motor neurons will have died if that happens? I think the other piece to this that's really challenging is just a bit of a sense of at the time we see someone, and I'm thinking newborn screening, has symptoms, having a discussion around what the literature shows in terms of the predicted long-term outcome with that, because that can help to set the scene. If somebody has some weakness and is really not making the same gains that we would expect for someone, for example, that's completely pre-symptomatic when we see them, that in my mind is a sign that motor neurons have been lost. And we want to be able to clearly state that as physicians and not have the waters be muddied and people be thinking that it's a sign of an incomplete response or failure of therapy. So I think there's a challenge with that. And then the last thing I would add is everyone's so interconnected now on social media, and there will be anecdotal stories of someone who started disease modifying therapy B after A and is now having better bulbar function or is stronger. And again, is that related to the medication or is that related to growth? We don't know. But it really can create a lot of hope for people that want to see the same benefits in their children that have some symptoms. It's really difficult. We do want the best for the children we care for. Absolutely, we do. But I just don't feel as the more scientific side that this is backed up by evidence. It's more based in antidote.
What I want to hit on after, I'm going to ask Giles and Portia to give the patient perspective on this idea of sequencing, are some of the practical approaches we could take in the system to develop that evidence, things like coverage with evidence development, outcomes-based contracts, ways that we structure both the provision and the payment for some of these therapies in a way that gets us some of that evidence. So everyone can start thinking on that a bit. But Tom, did you have something you wanted to chime in on quickly?
Yeah, I forgot the other point. At least for two of the therapies, we have a biomarker that is potentially there, and yet the companies are not terribly may not be terribly enthusiastic about using that biomarker because it could lead to winners and losers. Right now, they can make the statement. Neurofilament protein is a protein that's spilled from neurons. Babies that are pre-symptomatic have the highest levels of neurofilament measurable anywhere. And when you start either risdiplam or nusinersen, they drop precipitously and quickly, suggesting that it decreases. And so it's a very short-term measure of we stopped degeneration. It doesn't work so well for Zolgensma because the fusion itself likely creates a DRG damage and causes it to bump a little bit. So we can't use it as much or whatever. But this is, to me, I am greatly disturbed by the fact that the field has not jumped on this as much as they could, because we could answer some of the questions, at least on 2 of the 3 therapies.
Fantastic. We're going to work that into some of the future research needs there, because I could imagine that could be used in a system to help us know what's working and what's not, and in a way that could support an outcomes-based contract or coverage with evidence development.
And it was just used by Biogen to as the basis for the application to support the high dose nusinersen.
Right.
Is the major outcome measure that suggests the high dose was a little bit better than the standard dose.
And the standard dose. Thank you. Portia, go ahead.
I feel like the problem we have in SMA is that the outcomes and treatments are so individualized, with some responding better to others. And then when you have an add-on therapy, it's like, how can you tell if the benefits are due to the add-on therapy or if they would have just followed that trajectory anyway?
Right.
You can't have a control group because everybody is so different. So it's very, very difficult to know. And someone once, I think it was a clinician once, said to me that it's like putting sugar in a tea, and you can put as much SMN in as you like, but it doesn't get any sweeter because there's sort of this threshold of how much SMN is going to improve your function. But again, there's no clinical evidence for that. But yet in the UK, as I was saying, people are very hungry for these add-on therapies, and especially the Zolgensma families, because for them, looking at it from a layperson's point of view, the Zolgensma is impactful on your SMN1 gene, and the other 2 treatments are impactful on the SMN2 gene. So surely if you had both together, that's going to top you up beautifully. Whereas for someone like me who's just on SMN2, giving more SMN2, it might not do that much difference. But it's a really... you need to think about how the families are looking at this and try and find evidence that will, show them the truth.
It sounds like we need a lot more evidence there. Giles, please go ahead.
I think that is the key point. It's just gathering more data and more evidence.
Yeah.
And the magic recipe hasn't quite been found yet, whether it's a combination of X, Y, A, B, or C. We haven't quite got that yet, but we have to keep trying and have to keep getting people to go on combination therapies. I think particularly when you look at a UK context, is that the pathway to medicines being approved goes the FDA, EMA in Europe, and then into the UK. So we will always look for, the US to try and lead some of those ways. So it is super important that the payers do pay and try and find that perfect recipe, because it will cascade through the whole system. So then ultimately there will be even more real life data to be able to be put into the full picture.
Appreciate that. Thank you, Giles. Tom, you brought up the off-target effects on risdiplam. If we could just take a quick side street of this conversation of the prenatal use that has been discussed of risdiplam. If you or Dr. McMillan have any perspective on that just would be interesting for this audience to hear, for us to incorporate in our thinking, because that was a fascinating case study we saw.
So we have also treated the case. was just born 2 months ago. The baby's sibling died, presented in 2016 with substantial weakness at the time of birth and only survived 8 months. This one was treated at 30 weeks as opposed to Finkel's 32 weeks. The baby was born normal, and importantly, the neurofilament levels were normal. Whereas another baby just got born the day following, you can imagine, and they were 2.5 times the highest value we've ever measured. And so normal is pretty amazing. Kid's now 2 months old and is completely normal. So we do have a problem in that this looks very, very promising, and I would recommend it. On the other hand, there's kind of a runaway train going on here because now everybody wants it. I'm aware of 7 other families preparing for or already receiving this in around the world right now. And we don't have the infrastructure set up to do the kind of safety studies. And, 2 stories, mine and Finkel's, and another case in Germany that hasn't been reported at all, is not safety. We don't know are these kids going to be having thalidomide-like complications 2 years from now. It just scares the living Jesus out of me that we're going to go from a good idea and 1 or 2 great outcomes to standard practice so I'm not proposing we don't do it. I'm proposing we have to do this in a context where we're doing extremely vigilant kind of follow-up. I want to do it, but I have to do it the right way.
I appreciate that. Hugh, please go ahead.
Yeah, I was just gonna say I completely agree, Tom. Completely agree, and I think as part of that safety is also looking at and I'm looking at things that wouldn't normally look at with SMA. So we know with 2 copy patients, there's a much higher incidence of neurocognitive problems, language-based learning difficulties, quite significant. And in addition to the safety, we really need to follow these kids to see if, for example, treating them in the 3rd trimester normalizes some of those language-based learning difficulties that might otherwise have arisen. We also know that for autopsies that have been done on children with SMA type 0 that have died, there appears to be a number of children that have structural brain anomalies. So I think we know not only that SMN protein is very critical in that stage of fetal development, but it may have both an impact on synaptic connectivity and potentially even migration of some of the neurons. We're learning more and more as time goes on. One last thing I'd say is there's a really nice paper that was published by Michelle Farrar recently, and they showed in their Australian cohort that infants that were born early term or late preterm tended to do better, the 2 copy patients, compared to infants that were born late term or post-term. All of them picked up on newborn screening, all of them treated, but that suggests that, especially for the 2 copy patients, not only is SMN protein important for the brain, but the disease is just moving very quickly, even before the infants are towards the end of what we would consider normal term.
There's a part of this is starting to feel science fiction to me, like in a very positive way, but the idea that we could be doing an intervention so early. I picked up a question from one of our CEPAC members in the chat, and this is, my ignorance and not understanding. Is it, how do we know that the developing fetus might have this? Is it usually just because it's a sibling? Is there some sort of testing that happens, Dr. Crawford?
Yeah, so right now, you're as part of prenatal or early natal, mothers are offered the opportunity to do SMN carrier testing. And if it's positive, then you have a reflexive ability to do the second one. So that doesn't happen very often, but it does happen. That was or the fetal siblings. So there are some in utero diagnoses that are being made as a consequence.
Oh, thank you for that. Okay, thank you for that little side note, just in terms of where we might be headed. For
I have to emphasize, Hugh's got it completely. We haven't mentioned all, but this neurocognitive thing in the 2 copy kids is looming and is probably the big future. And I'm experiencing some disappointment that the community is not organizing around the kind of assays to really study this, especially there's like there's a whole bunch of things we could study that are not being collected right now, and it's driving me crazy.
Yeah, and it may have to do with, in terms of that earlier question about is one treatment better than another,
Yeah.
looking at some of the really rough data, the kids from the Rainbow Fish study that were treated pre-symptomatically, they didn't report any language problems in those kids. Now, I know
Too
the
small.
numbers are small,
Too
and
small.
we can't extrapolate from that, to either, sprint or nurture, but I think we need to start looking at some of these other areas in addition to just motor function.
Yeah.
We'll be noting this in future research needs, because in addition to the sort of language development, the neurocognitive, we heard from Susie earlier about the mental health. And so there's opportunities here to be thinking about the other impacts that are not just the motor function, which has been the focus, which understandably for sort of your first round of understanding treatment impact. But this sounds like an important need from a research perspective. So we'll note that in our future research needs. Quickly wanted to just reflect on our conversation and votes that we had on the other benefits and the special ethical priorities. Significant unmet need. Our council definitely voted on that. Not much on the special racial ethnic group of consideration. And then reducing caregiver impact. Now we're talking about the potential impact of apitegromab. Neutral to agree was where we sort of landed. And improving access by mechanism of action. Not sure I even want to talk about it because those answers just were all over the place. But did want to give all of you the opportunity. Anything you wanted to reflect on, anything that surprised you in those votes on the other benefits in our special ethical priorities. Giles, please go ahead.
Just around the carers point, and I think it is so important. It's often missed, and we always talk about the patient, and we always talk about the person at the heart of this. But the way I kind of think about this, it's like dropping a stone into the water and watching the ripples go out. So, you've got the patient in the middle, then you have the parents, you've got the siblings, you've got the grandparents, you've got the schools, you've got all of that. Then you have the other things that cost time, money, etc. The adaptations, the kit, the car, the house, everything. And I think sometimes we just lose sight of the wider and the bigger holistic picture, not just simple patient measure outcomes or complicated ways to gather those outcomes, but it's so much more than just the kind of the drop in the ocean.
I appreciate that, Giles. When it was either our previous SMA review, one of the reviews we did in Duchenne muscular dystrophy, we gained such an appreciation for how it can also be an entire community that reacts, whether it's the school or the town makes modifications to a playground, and all of the things that do ripple out from that, that are benefits and impacts that we don't typically try to measure. And we could do a better job there. Thank you for that. Any other reflections on those votes before we get nerdy about coverage policy? Go ahead, Hugh.
The only other minor comment I wanted to make is I agree that in North America, there's no racial disparities with regards to SMA prevalence. I would point out, though, is that with newborn screening, it does appear that there may be differences in terms of birth prevalence in different countries. So Eastern Europe, Ukraine is reporting birth prevalence in the range of about 1 in 6,000 to 1 in 8,000 births. I know in Ontario, where we've been screening for over 5 years, it's leveling out to about 1 in 12,500 births. The other thing I would add is that there does appear to be variability in terms of SMN2 copy number in different areas. In Ontario, it's very much like Tom described earlier. The majority have 2 copies, about 60%. In other jurisdictions, 4 copies are much more prevalent. So I think as we start to hear more reports from newborn screening programs, I think we're going to start to understand that there is variability in prevalence around the world, and there is variability in terms of SMN2 copy number.
Something for us to be watching for. Thank you for that. I did want to shift to talking about what all of this evidence or lack of evidence in some cases, these contextual considerations, the things that we want out of an ecosystem that's giving sustainable access to these therapies. Let's talk about what the coverage policies need to look like in order for that to happen. Emily, let me invite you to share a little bit about, since there are approved therapies, this is an area that you've already had to be thinking about. Give the audience a sense of how Premera has approached coverage for the disease modifying, and then if you would, bridge to what you're thinking about for apitegromab.
Yeah, Sarah, I think that, our policies are fairly in line with the rest of the country, as far as I know. I think in terms of how we're thinking about apitegromab, again, I just want to emphasize there's the policy, which is evidence-based, but I think, really some of these factors that we've talked about that are difficult to put into a policy and really have that be clear are really handled offline, right? And the actual review by review that are done. And so I think for me, my focus is more not so much on maybe the criteria and, trying to factor some of this into the actual bullets that are in the policy, but the process that happens on the back end and ensuring that all the considerations are taken into the review process.
Lindsay, same question to you in terms of anything that you want to share about your current approach to these therapies and how you're starting to think about an apitegromab policy.
Sure. The current therapies out there, they're so different. I mean, when we're talking about step therapy or even add-on therapy, it's really hard to steer at this time with the evidence that we have, nor would we want to, a patient to a specific therapy because each patient is unique and each therapy offers potentially a different pathway to treat where they're at in their current condition. So that's kind of current state. And I would agree with Emily. I think we're very in line with how the rest of the insurance companies out there have structured their policies. For the new therapy, it really is always going to be evidence-based to start until we have additional information. So today, going through the review and then all of the clinical trials information and just other data that's available to us, that's all going to be factored in on day one. But that also that's just a snapshot in time. So when I think about how this could evolve over time, it's not just this one decision on how we're going to cover it today. It could very well evolve within 6 months, all the way, in perpetuity. So I do want to just put it out there. It's something that we're constantly reviewing and it's ever evolving.
Tom, I am going to you first this time because you've dealt with a US payer system and Hugh has not. And so I want to offer you the platform to talk. Has it been easy and flexible? Has it been responsive? Are there areas for improvement in terms of the work that your office has to do to get coverage for these therapies?
It's perhaps a little bit unfair because as an SMAologist, we've developed the systems and we're successful. So I don't know that I represented it. Probably more relevant to somebody in a remote state who's doing it for the first time and doesn't have the resources and things going through. My sense of this, what I hear from other people is that they're having lots of troubles.
Okay.
I'll leave it at that.
Okay. Well, I mean, what I would offer just from sort of being out in the wild, talking to, we've done several reports of barriers to fair access for patients. We have lots of conversations with patient groups about sort of the challenges. Every once in a while, you do encounter a coverage policy, and it will exempt present company from this generalization. I remember reading about a payer that had a coverage policy where the physician had to submit that the patient still had the genetic marker for cystic fibrosis in order to continue coverage. And I giggle there because we at least don't yet have a genetic therapy for CF, and so those genes aren't changing. And so that just seemed like busy work. That seemed like paperwork more than something that was clinically important. And so we always want to be aware of the coverage policies being evidence-based, not having burdensome criteria that seem to be just to make it hard and not really for clinical consideration. For me, just reviewing some of the coverage policies across the country, the one that I'd love some reaction to was sort of the criteria for renewal, and especially for the disease modifying therapies, since any break in therapy could mean progression. It seemed like this could be an area where maybe we could have it be a little more streamlined, but I don't know if anyone has had, I don't know if that's been a problem for you, for your office, Tom, in getting sort of renewals, or again, since you guys have a well-oiled machine that's been going well.
We're never going to do the experiment of how quickly people deteriorate after withdrawing a DMT.
Yeah.
I don't advocate for it.
No.
And so we're dependent upon proms and stories to do that. But
Okay. All right. Well, thank you for that. The other area of the coverage policy I'd love some reactions to is, and let's talk about apitegromab in this case. What kind of provider restrictions, if any, make sense? Should this be limited to an SMA specialist neurologist? Is this, since it's IV, maybe fine for any neurologist? Would we imagine it in any other setting? Who wants to take this one?
with respect to risdiplam, I'm a little bit worried about the fact that it can be prescribed by anybody, because anybody does do it, and that means that people miss the opportunity to have somebody who knows how to manage the pulmonary disease, nutritional use,
Okay.
that kind of stuff. So there is purpose to folks, maybe not all the time, but checking in with an SMA concentrated specialist on a routine, but maybe somewhat infrequent basis, just to be confident.
Okay, in consultation. We've seen that in coverage policies before. So specialist or in consultation with. Okay, great. Lindsay, you brought up outcomes-based contracts before, so now I get to put you on the spot, and let's unpack that. So the Midwest CEPAC split vote on whether there was enough evidence to demonstrate a net health benefit for apitegromab, but we've also, I think, all embraced the challenges here with PROs, the heterogeneity of the treatment effect, the different course of natural history for this condition, dependent on the patient. Tell me how you're thinking about an outcomes-based contract. What could work here?
Yeah, it's very complicated, and I probably, whatever I say here, it could evolve into something new, but I definitely would like to find some way to incorporate maybe some of those patient-reported outcomes. I don't know of an outcomes-based contract that we have that is available in the market today without something like that. I think it would be very nuanced. That could be an avenue. I do want to say that the add-on therapy portion of this is of interest to our clients and potentially the market, because there isn't a ton of evidence to say that that type of regimen really works well. Maybe that's an area where we can try to do some sort of outcomes-based contract to get more patients on therapy, try it, mitigate some of the risk, do some risk sharing. I think that could be potentially a win-win, but it is not easy. And anything that we're going to do is definitely going to be very patient by patient. But I think with the development of where we're going and all of the gene therapies and other really interesting therapies in the pipeline, we're going to have to get more robust in how we approach contracting, but also risk sharing. So
I appreciate that point. And what I've been thinking about on the apitegromab space, because it's not a disease-modifying therapy like the other three, but there's some evidence here, and we've heard from patients and clinical experts about the big benefit that you get from being able to pull up your blanket at night or roll over in bed. So it's not that there's no value in that. Let me bring in price. So we don't know what Scholar Rock is going to pick for a price. Many analysts have pegged it at about $350,000 to $360,000 a year. We have a vote from our Midwest CPAC that they're not convinced yet that the evidence is there, that there is a net health benefit. I can't help but shake the feeling that some of how payers may approach this will consider the economics given the price tag for something that might not be delivering a lot of benefit for patients. And if we had more of a system that rewarded what we like to call at ICER the grand bargain, which is the idea that if you price the drug in line with the benefit that you've been able to demonstrate so far, then payers should respond with easier access and maybe no cost sharing or very little or modest UM. And I would love some reactions to, would that make things easier, I would imagine, for all of the participants if the prices were reflective of that in a way that maybe they can raise the price later when they have better evidence that it works better for patients. But right now, thinking about that kind of price tag for something that has a lot of questions about the real benefit to patients and that magnitude of benefit, maybe we're better off with a value-based pricing approach. Tom, I'm calling on you because you're smiling. So please, please chime in.
Well, I talked a little bit about how are we talking about scientist or advocate?
Right.
If we want to talk about citizen, this is where, I'm not, I like the people at Scholar Rock. I've been working with them for the longest time. I believe in this thing. I think it works. And I'm terrified about the fact that they're going to charge gazillion dollars. And so they have to they took a huge risk. And I understand economics of it, you have to get paid back for your risk. And so I don't know what that price is, but boy, I would love to. It would be wonderful if it was cheap and affordable, so that we can actually spread it out and get it tested on much broader ones. But doesn't this require an act of Congress or much more political stuff? And I don't know. I'm not in that world, so I don't know how to deal with that.
The only entity that picks the price is the company. And so Scholar Rock has the ability here to make a choice about price.
But a value-based system where we were, for example, to scale the price based upon what kind of benefit you had is not legal presently. And I would love to see something like that.
Well, it's voluntarily legal, and it does happen. And so, we get stories from payers and manufacturers who've used the ICER report in order to get to that. And really, some have publicly touted how it's translated into better access for patients and more for affordability of healthcare premiums. So it's an entirely voluntary system right now. And Emily and Lindsay, I don't know if you want to comment at all, even just sort of conceptually, about how you think about an independent analysis of price and when manufacturers are doing the right thing by picking that price. Go ahead, Lindsay.
Yeah, I mean, I would love to see a value-based price on day one. I can't think of an example in this immediate moment where that has happened. And I think that's the issue. And what we as coverage policy writers creates us to be skeptical about offering these therapies at complete patient access when we don't have all of the clinical evidence on day one that we want. And also the prices are high for what the clinical evidence available is telling us it should be priced at. And so that to me is the big issue. And I think over time, like I said, as we get more information, we'll modify our criteria. But it would be fantastic if we could skip all those steps, start from what you said, which is a value-based price right away based on the evidence that we have using some sort of third party. But it takes two to tango, and I hate to use that phrase, but that really is what it is. And without having a partner on the other side, we're not going to get there.
Yeah.
Emily, what would you add?
Yeah, Sarah, I think the only thing I'd add is, there's risk here involved with having high prices, right? Like what scares me the most is getting an email and saying there's this, self-funded group, maybe like a smaller one where financial toxicity from gene therapy utilization is a real risk, and they just want to block gene therapy coverage. It's a benefit exclusion. There's no like discussion about medical necessity. That still happens today. Those requests still come in. And so what scares me the most about this area is that we have add-on therapy costs. And then, some of these small self-funded groups, like it's, you pay for the treatment or the company goes under and they have to make that decision. So, I would just say that, these high prices, they really have a risk involved in the real world.
Emily, it keeps me up at night. The stories that I'm hearing from the health plan and purchaser community of the number of employers who are now carving out access to gene therapies is exactly the wrong direction, but is an exact reflection of the financial toxicity that they are facing. The number of purchasers that I've heard from recently are reporting 10, 15, 30% premium increases due largely to the use of prescription drugs. Or they are thinking of shifting the way they do health insurance entirely to a less generous benefit, or something called ICRA, which, you know, is basically like a health savings account and good luck. Like there's a lot of worry that I take home every night about where we're headed if we can continue on this trajectory of not paying a value-based price. And so we'll come off of my soapbox now, but I appreciate that you all endured that with me. Lindsay, go ahead.
I do just want to reiterate that the unintended consequences too of price toxicity is not just on one patient population. So what Emily just described is if one manufacturer takes a price increase and it impacts that patient population, it's going to have a trickle down effect to all sorts of diseased areas. And so the impact of that price toxicity that you just described is going to be systemic here, if not already. And that is something that I think is going to just be multifaceted. And we're going to need additional support in order to combat where we're headed.
I still think it's a shared responsibility. And then this is one of the reasons that we hold a public meeting and we have this roundtable where we invite all of the stakeholders, because I don't think it's only one actor's responsibility. And it comes from prescribers using evidence to make their prescribing decisions. It comes from payers making decisions based on value and clinical effectiveness. It comes from the patient community participating in conversations about the price and the access piece. And it's, you know, on us at ICER to continue to do these convenings and produce the information so that we can de-escalate this arms race. Go ahead, Tom.
So if we talk about soapboxes, one thing is an academic who wants to only do good, because I'm in this privileged position where I only have to do that, but I will self-immolate if I were to try to work out a way to actually produce a meaningful value-based system for gene therapies or other things. This would mean that nobody would want to work with me. And so that is like the end of my academic career. So that's a structural problem.
But Tom, do you mean, but when I think of a value-based system for gene therapy, so it's an interesting example because most of ICER's analyses in gene therapies, the prices in the millions of dollars are actually value-based. What I want to see out of the system is that we have plenty of money to pay the millions of dollars for the gene therapies, because again, many of those are priced fairly, but we get that by stop overpaying for some of the other things that have marginal clinical benefit, but big price tags. So I hope that helps sort of clarify. I'm not, and I don't want you to self-immolate. That is, I should have led with that.
Yeah, well, as an academic, there's a great need for this kind of research.
Yes.
And there's no entity that I know of that is fostering that kind of research. And that's
You're getting at the point of if there's an innovation signal here, that means less money for the biopharmaceutical ecosystem to be investing in this, then we don't have the research. And that is what you're worried about.
Yeah.
Got it. Agreed. And you know, it's part of the pillar of what we do here is we think there is a balance between a value-based price and plenty of revenue for more innovation. That'll be another roundtable that I'll invite you to that we'll talk about some more. We're almost ready to wrap up, and this is your warning that everyone's going to get a final call to action or summary. We like to say it can be one sentence with one semicolon, but you know, just as you're thinking about what you want to sort of leave this audience with, leave us with as we write up the policy recommendations. I did want to spend just a minute or two on future research needs. We've touched on a lot throughout the day. But Giles and Portia, let me start with you. You've listened to today. Again, thank you. It is already sunset in the UK. We appreciate you hanging on this long. Tell us what is top of mind for where you want the research enterprise to go as it serves patients. Go ahead, Portia.
You know what I'm going to say, don't you? It's all about proms and all about making measures more sensitive. And in the UK, of course, we have a system where if there's not enough data, then we recommend the drug for a set amount of time to collect more data and then look at it again. I don't know if that's a thing in America, but I think it's a great idea as long as you get those systems right and you get the proms right and you get the measures right. I think there's lots to learn from what we've done in the UK, and what we've done wrong and what we've done right. But yeah, let's look at those sensitive changes and the impact on not only the people living with SMA, but their parents, their carers, and the economic situation as well. I mean, I had to give up my career to look after my son.
Right.
With newborn screening and early treatment, that wouldn't have happened and would have saved us all a lot of money.
Right. Giles, research.
Yeah, I mean, for me, the kind of final point is we can't stop trying, we can't stop innovating, researching, gathering data, the real world stories, and just trying to look to do things differently. I think we have to look outside the box. We have to keep banging the drum and doing everything we can because we know that we can change the future. And these little marginal gains are significantly important. I think if anything can go down that route, we should continue so.
That's great. Anyone else have a call to action for the research agenda before we continue with sort of final thoughts?
One thing is that there's this sense at the NIH and other places that SMA has been solved because we have the DMT. That's a real problem because we have a whole bunch of other new ideas, the cognitive impairment, but you know, the fact that we have a whole different dimension of being able to improve muscle mass in somebody with SMA, this is potentially much broader than SMA. This is potentially useful for a whole wide range. And so to me, using SMA it simplifies the clinical trial paradigm enough that we could actually show a modest benefit, but a real benefit in my mind, is something that model needs to be extended and celebrated. And so this is one of the reasons why I wish the company well, because I want this kind of activity to continue. And if they're slammed, then that's going to be a commercial. People say, well, what the hell? We can't use this anymore. I'm worried about that.
Thank you. Other research, other things for the research agenda.
The only thing I would add, if it's okay, is just to say that I think the research agenda really needs to help inform our decision making as clinicians and as third-party payers that are on this call as well. So making those really tangible recommendations about, just for example, is there value in adding risdiplam or nusinersen after gene therapy? Show us if it does or does not make a difference. It's going to answer a lot of those difficult questions for us and make sure that we are making recommendations that are aligned with our patients' needs and also being cognizant of the ever-increasing costs that we all collectively need to be aware of.
Thank you. Lindsay, go ahead.
Yeah, I was going down the same pathway, and it really is getting that real world data too to help support those decision points. And I do think it's just very important to continue, even though it's difficult, and we've used the word heterogeneity in this disease state, but trying to find patterns to optimize treatment therapies to maybe patient situations, trying to individualize treatment and figuring out maybe these therapies could be better in these types of patients, or XYZ layering could be better in this type of patient, and helping inform us from that perspective.
Can I ask?
Yes, Tom.
I'm interested in payers' perspective of this. What is going to be necessary to allow much more sensitive biomarkers as a condition for approvals? Because being able to show that a heterogeneous population is 10% better a year and a half after we start a therapy involves sample sizes and costs and trials that are never going to be achieved. but with more sensitive short-term biomarkers, they are if they're valued. And the problem is how do we get to that point where that would be, you know, if I could show that I've increased muscle mass
Right.
by 20% with apitegromab, would that
Yeah.
enable an approval?
Let's get Lindsay a quick response, and then we're going to wrap up with final comments. But go ahead, Lindsay.
Yeah, I would just say whatever the metric is, I would like it to be clinically significant in additional data point. So I'm not saying it's good, it's bad, or whatever, but it needs to have clinical significance in that regard.
And I would say that that's the big thing. And we covered this in a white paper we did on accelerated approval a few years ago, Tom, just that the use of surrogate outcomes can make a lot of sense when they're linked to a clinical benefit that patients care about. And that can sometimes be hard. Yeah. All right, we're going to go around the horn in the last 5 minutes here for any final call to action, reflection, anything that you want to have in our heads as we work towards developing some policy recommendations based on this conversation and this meeting. I'm going to start with the payers. Emily, you get to go first.
Well, I just wanted to thank the patient advocates, you know, for sharing your perspectives. The comments that I've heard today have been so helpful, and I would just encourage the manufacturers to continue or start engagement in partnership to make these therapies more affordable.
Thank you, Emily. Lindsay.
Yeah, also want to thank everybody. I've learned a lot, even just being as a panelist on this call today. But I think as parting words, you know, I don't want to be the barrier of innovation. So as a payer and someone who's developing the clinical policies, I still do really want to see innovation that we can tie into our coverage decisions.
Thank you, Lindsay. Tom, I'm putting you in the middle.
I've talked way too much this time.
Not at all.
I don't think I have much. I've said my piece.
Oh, Tom, thank you. Appreciate you being here. Hugh.
Yeah, I have to say, I don't think I have anything else to add either, Sarah.
You guys haven't said too much, by the way. You've been fantastic, and the contributions are well noted. Okay, thank you. Well, then, Giles and Portia, you get to take like a full 4 minutes here. You got a captive audience. Portia, what do you want us to have in our heads?
That's a risky thing.
Was that a risky invitation, Giles? Okay. Go ahead.
Keep the cost down, I would say. It's all about the cost. We're only going to get it if it's not too expensive.
Right.
That cost benefit thing is super important in the UK, and I know it is in the US as well. If these add-on therapies are just as much as the SMN targeting treatments, we're not going to get anywhere. So yeah, please keep the cost down.
Thank you, Portia. And Giles.
Yeah, I kind of just echo that and everyone else on the panel. Just a really great opportunity to speak and things, and it's so refreshing to see so many people interested in continuing to research and look at SMA, trying to change the dial and really trying to change the future for not only people now that have SMA, from kids to adults, but looking ahead to the future. The opportunity now and the things that we do now could actually absolutely change everything forever.
And I'll end with deep gratitude for all of you spending this time with us today, the insights, the perspectives, the good humor. But I want to end where I started, which is, and this ties into the point that Emily and I were just discussing. Some of you know that I spent 10 years in industry, and one of my jobs was at a company that was doing genomics-based drug discovery in the early 2000s. And I thought maybe I'd live long enough to see therapies based on what we were uncovering at that company and decoding the human genome. And here we are. And I worry about the trajectory that we have been on from a price, access, value trajectory, that we're going to leave a lot of people behind because we're not headed in a positive direction from an affordability perspective. And that with a lot of the other macro things happening in our system that we will just leave uncommented on for today's conversation, I have worry that if we don't bring our best selves to de-escalating this arms race, that we might have real consequences for patient access. And I think many of the people on this call and participating in our conversation to know that oftentimes those initially harmed and harmed the worst from those types of access restrictions or increasing costs are people who are already historically disadvantaged by our system. And so I have a call to arms for all of us to keep showing up for these conversations, and bringing their best selves to those conversations, stay focused on solutions. And that's everything from the prices picked by the manufacturers to the coverage policies developed by the payers to the treatment decisions that clinicians are making with their patients. And patients, you just keep doing you, and we will, if we keep showing up, be able to get out of this a little stronger than we are now. And so with that, it's really, again, my deep gratitude for everyone's participation in this roundtable today. And Jill, I'm happy to hand it back over to you for some final reflections from our Midwest CEPAC.
Well, thank you so very much, all of you. Okay, so I guess we'll start now with, I guess, our lineup of Midwest CEPAC members who would like to give your final thoughts for our SMA day. Let's see, we could start with Stuart.
I'll probably echo what a lot of people are thinking based on what's been in the chat, but I think the Midwest CEPAC has been extraordinarily well served by ICER staff, by the patient community, and by the clinical experts today. I don't think I can overstate that. I was especially moved by the descriptions of perceived value in even small improvements in motor function in these patients, and that's what I would like to stay focused on. Thank you.
Brad.
I guess I'll have two comments. One, it's not often I sit at a panel where Americans are exalted for doing something right in healthcare. So, and with our genetic screenings, so that was kind of nice to see. And then the other is, again, the clinicians were fantastic. The report was well prepared, and the patient advocacy certainly made us feel what it was like to be a parent of a kid with this devastating illness. And I think one of the challenges with this is the law of large numbers, the lack of it. You have drug manufacturers bring in products that don't have the patient population base to support the risk, and you have small employers that are going to carve out these potentially expensive technologies because they can't spread out the risk over large numbers. And that's a conundrum here in the United States. That's it. Thank you.
Thank you. Gianni?
Hi, can you hear me?
Yes.
Okay, great. Yeah, I just want to first thank you, the patient experts as well as the clinical experts on this call. It was very helpful to get their perspective on it. And yes, the cost piece was an issue, and also lack of data or proper data, I guess, for that was a issue in terms of voting. And parting, I was just thinking actually, especially in terms of Giles was talking about ripple effect on the family and the society around in the patient, not only focus on the patient, but also the ripple effect on the siblings, the parents. Portia was talking about she had to stay home, give up her career, etc. So I was wondering if there could be, I'm not sure like whether there has been any survey data gathered on the impact on caretakers and the family on this condition, and if those could be also in the future could be incorporated into the report. That would be helpful as well for us to see the impact overall, not just only focus on the patient. While I understand this is about the clinical evidence, but I think the ripple effect to understand that would be also helpful. Yeah, I think I'll stop there.
Thank you. David.
Yeah, thank you. This is actually kind of my first experience as a CEPAC for the, add-on therapies among the population with a rare disease. My work mostly surrounding like cardiometabolic disease that's very prevalent. So the experience is really enlightening for me with the wonderful patient and clinical inputs to hear their perspective, how to deal with like rare disease. And again, I think it exposed the struggles that I have. The evidence presented was insufficient in many ways for me to make a conclusive decisions, I guess. It was insufficient to differentiate signals from noise, insufficient to understand heterogeneity, and then more importantly, insufficient to capture outcomes that are relevant and matters to patients and caregivers, as we heard from the many of the patients and the clinical experts. So to me, like this exposed like the fundamental challenges in how we are going to generate sufficient evidence for rare disease. And really, I would echo that we really need to think about like innovative and efficient trial designs, coverage payment models, probably supplement with like the simulation modelings to supplement like the clinical trials data to support the advancement of drug development for rare disease. So thank you for all those great, wonderful inputs and experts.
Bijan?
Yeah, thank you. I honestly, I learned so much, and it's not just today. Every time we come to these meetings, we kind of, we as an economist, kind of, we do the things like, the technical things. But today, again, we learned quite a lot, and I really thank you, ICER, for assembling all these various stakeholders that matter, and particularly the patient advocates who kind of care for these patients, and the clinicians who have lived experience of caring for these patients. So thank you again, and again, thanks for everyone's input.
Thank you. Reem?
Thanks, Joe. So I'm going to echo some of what's been said. I'll try to say a couple additional things. So definitely a big thank you to ICER, to the evidence review team, and the cost analysis team for doing a wonderful job. Almost everything we brought up have been thought about, even if the answers are not there, and we appreciate that. Jill, I want to thank you for your wonderful chairing of this group, and for the excellent discussions. And they could not have been at the level of thoughtfulness that they were without the support of our two wonderful clinical experts and the patients' representatives. And I would just want to acknowledge that, especially for the patient's representative, to actually take the time and share those experiences with us, and to be so selfless to go beyond what may or may not have direct impact on you and your family right away is noticed and appreciated. So thank you for that. It is very obvious that we do need better sensitive tools, or better, more sensitive outcomes to make more progress in this field, because we can't just increase the number of people. But at the same time, I want to just kind of note that we can have the tools and we can have everything, and we can show better benefit or not. If the medications, if the treatments are not affordable, even if they're cost effective, they're not going to reach the right people. Affordability is a huge, huge point here, especially when you're adding on medications. So a plea for the company, and an appreciation for moving this forward and getting us to this point, to really carefully think about the price. And the last thing I'm going to say is also a note for all of us. Sarah reminded us that work in this area and this type of treatment started years and years ago. So it is really our responsibility to continue to support science, to continue to move our fields in medicine and science collectively and incrementally. This takes years to get to where we are, and it is actually a very good example what's happened with this condition, that we did change a disease from being totally fatal to now people not only talking about living longer, but actually being active participant in the community. Thank you.
Thank you, Reem. Timothy?
It's always hard to follow Reem. She's so eloquent, and others have great comments. So I want to just echo that, and especially thank ICER for internationalizing this meeting and having a lot of wonderful accents to listen to. It was really fun, and really the clinical and patient experts were brilliant and moving. That's my main thought right now, is just thinking about, I'm a father of a child with special healthcare needs, so I wear two hats when I come to these meetings as well. So I heard them wearing that hat as well, being very brilliant in their thoughts. And so I come to these meetings and I have to say that I have a prior that I want to vote yes in favor of the patients, where there's clinical evidence and cost evidence to suggest that it would help. But I landed, and I thought I might be the only one to be voting that the data was insufficient, but apparently I wasn't. So that's where we landed, and that's why. And it's not because we don't care. It's just because we do care about the data and the evidence. So, and I think that matters a lot. So great job again by ICER and the others. Thank you.
Thank you, Don.
Sure. Thanks to everyone. It's always a great honor to be with the Midwest CEPAC. I think this is to highlight a point that Sarah made in Policy Roundtable, this challenge and opportunity of what will very likely be helpful data in the next few days or weeks when we get the publications around the heterogeneity of the patient population here, because obviously it's at this point it's been difficult to sort of compare the severity in the outputs. I particularly appreciated Giles and Portia bringing not only their personal perspectives, but they're really experts in terms of understanding the disease, and that always helps a great deal. I will say that just tell a quick story about atopic dermatitis, which I know has nothing to do with SMA, but may be useful and encouraging to you. I remember when we first discussed this several years ago, the actual rubrics of the patient-reported outcome measures were rather primitive. And lo and behold, over time, over the next 3 to 4 years, we have a much more robust set of measures that have really helped guide the field. And I'm hoping that SMA will have the same experience as it moves forward, because you're obviously not stopping. So best of luck, and we hope for the best. This is a serious problem, and there's got to be something we can do much better. So I look forward to hearing that. Thank you.
Thank you, Stacy.
So like everyone else, I want to start by saying thanks to Giles and Portia for the excellent contributions today. I also want to say a special thanks to our clinical colleagues. I think that both your enthusiasm and your passion for the work that you do is very clear. But I also really greatly appreciated how clear-eyed you were about the data or lack thereof, and how challenging that makes your job as a clinician. So just very appreciative of that. I think as I consider the report and the evidence, one of the things that I think would be incredibly helpful just to contextualize for the audience and for others is this, differences among prevalent populations versus incident populations, and also the effects of the screening and what we think that means moving forward. And I think, especially from hearing from our colleagues and friends in the UK, that, global screening is not happening everywhere. So, I think even having a bit more context to understand that while that is now the standard in the US, that's not the standard everywhere, just to give readers a little bit more context about the use of these treatments and how they might evolve over time. But thank you so much to everyone, as ICER staff as well, and those who were leading the clinical evidence review and the economic model. It's a great meeting.
Rachel?
So I also want to thank the clinical experts and the patient experts, especially for providing their incredible perspectives, in addition to the great ICER team. As a law professor, Dr. Crawford, I'm happy to talk anytime about what might be required legally in order to accomplish some of these policy goals, so just let me know. My point is closely related to Stacy's, I want to emphasize the data theme, right? The data many of us are really hoping to have about these technologies. They're not just things that might be nice benefits as part of the regulatory approval process. They're really important for patients and clinicians as they're trying to figure out how to make informed treatment decisions. And I really hope that manufacturers hear the frustrations that we've heard today and take that more seriously.
Thank you, Rachel. Sneha.
Yeah, this was such a informative meeting, and I think, like David, this was my first meeting focused on ultra rare diseases and pediatrics. That was really exciting for me as a formerly pediatric patient as well. I think this meeting was really exciting, and I think hopefully opens up the opportunities for more engagement with manufacturers as well as patient groups based in the United States too. I find these meetings, as someone who runs a patient advocacy organization, incredibly, incredibly important to think about what evidence exists and thinking about a fair price based off of what evidence is presented by the manufacturer. And so I hope to see more engagement in the future for therapeutics and therapeutic areas like this as well. The second thing I'll just say is I remember reading the report and there was mention of fatigue. And I just really want to underscore how crucial and understudied the symptom of fatigue is, both, within SMA, but likely across many, many other conditions. Both fatigue and brain fog are pretty significant symptoms. And I think whether that's pre-therapy or post-therapy, I think it's really important to address as outcomes that really are debilitating and huge quality of life barriers for so many patients. And the last thing I'll just say is, given that this is a pediatric, this therapeutic area was more focused on pediatrics, I think especially as we're thinking about outcomes measures from manufacturers, I'm really excited to hopefully see researchers and manufacturers talk more to pediatric patients in ways that make sense to them. I really, really value the perspective, of course, of caregivers and parent partners. I mean, I can't have more respect and appreciation for all of the caregivers, especially you, Portia and Giles. But I do think that there's opportunity and room to talk more so to pediatric patients and ways that make sense to them to account for outcomes that are really mattering to them. So that's what I will say. But thank you, ICER team and everyone, for a great meeting. I really did learn a lot in this meeting. So.
Thank you. Are there any other Midwest CEPAC that I've missed? I'll go last. Thank you, ICER team. Another great meeting. I think my frustration lies in the realization of however many great drugs are being discovered, screened for, that the unaffordability continues to be a problem. You all have talked a little bit about the fear of having these great drugs and having plans exclude gene therapies altogether. I can tell you it's not from my center who's recommending that. We are not, but I can tell you small employer groups are carving those out uniformly, no matter if some of the gene therapies are fantastic and some of them aren't. They throw them all out. And it is, I understand it. They simply can't afford it. They're such small employers, they just can't afford it. So I think it truly underscores the importance of manufacturers behaving responsibly. And I just can't stress that enough. It's a highly frustrating thing for me to be a part of. I love being a part of ICER, however small my part is, but thank you for such a great team. Y'all are so easy to get behind. I mean, everything you say, I can hear today. Y'all have listened to each other. Y'all have listened to our wonderful patient experts, our clinical experts. You've listened to our clinical team. It's just a fantastic working situation. And the transparency is so important, and ICER is succeeding in that as best you can. It would be great to have all the manufacturers involved completely 100%. But you guys are doing great work, and I'm proud to be a part, however small. Thank you.
Jill, thank you so much. I think we had one final slide as we wrapped up today that I'm happy to talk through, and then we can adjourn. We will be posting the meeting recording next week for those who want to relive it, listen to it on 2x speed. Just don't judge me for how I sound on 2x speed. The final report will be published on or around September 2nd, which will just talk about the votes, the discussion of the votes, and then the policy roundtable themes, excuse me, and policy recommendations. There's a link you can use to get some more information. And with that, Madam Chair, may I adjourn us for the day? Okay, thank you all very much. Appreciate it and have a great weekend.